Sir, you did talk about chromium picolinate. You did talk about these things. So, from your point of view, I'm not talking of what's evidence now. I'm talking about what's happening and what do you think in the domain of nutrition literature or nutrition evidence. Is there some small emerging evidence coming, and which would probably see large scale trials and later on change the way we actually improve metabolic stability in ICU patients? See, I'll tell you this. I'll give you a simple striking example of Dr. Paul Murray, who basically came, we all know he came with vitamin C, hydrocortisone and things like that, and actually said that it works in sepsis and metabolic control. Similarly, in nutrition spectrum, I'm not saying it's evidence now. What do you think would be the evidence in the future, which would come in the future? And I won't say that you're on 2027 that you're wrong what you said in 2025. But what do you think would probably be waiting to break boundaries?
Okay, are you specifically talking about chromium?
About whatever you have in your mind when it comes to diabetes and nutrition.
Yeah. So first, let me just finish up about chromium. The European guidelines, if you go into the discussion, will say that there is no evidence to show that chromium has any role in insulin sensitivity. But rather strangely, Sanjit, they add a sentence at the very end to say, in a patient with high insulin requirement, they don't define what high means. We recommend giving additional intravenous chromium. Okay, correct, why? Correct. We don't know. The American guidelines say just the opposite, just like iron or something. So, doing studies with radioisotopes is impossible in trace elements. Therefore, whatever is present in the formula, that is fine. You see, but you don't have to give extra chromium thing. Now, you asked a question about specific ingredients in the management of diet in diabetes. Okay, so there we have to be very clear in our mind and say, is it the ICU or is it the non-ICU? Okay, we have to be very clear. So let us just sift through this and analyze it logically. There is a very nice paper which I think I sent you. I'll send it to anyone who wants it. From Current Opinions in Critical Care and Metabolism in 2022. There is absolutely no evidence to show that the use of diabetic-specific formulas has anything to do with length of hospitalization, length in the ICU, time on a ventilator, infectious complication, or any form of morbidity. There is absolutely no evidence at all. Then why use it? The reason is because glucose control becomes easier. And also, we have to look at, if you need more insulin, naturally it is beneficial. Now then again, Sanjay, it depends upon whom you are talking to. In Europe, where the government pays for everything, no one cares about the cost. Whereas in other countries, especially India, the patient has to pay for it. Therefore, it is true that the amount of insulin and the glucose control and all that becomes easier with the diabetes-specific formula. Okay? Now, Sanjay, suppose you have a doctor who says, well, it costs twice as much as the regular formula, and why don't I just use the regular formula? It is absolutely yes. There's a fantastic paper by Evans and Hegazi in 2018, which clearly shows that there is no big benefit. You can use the regular formula too. So what do I use as a practice? Not everything is hyperglycemia or diabetes. If the diabetes is difficult to control, it makes it easy for you to do it. If it is just something that can be managed very well, as Sangamitra said, you can use the regular formula. Now, are we going to see any changes? So this is in the ICU. Now, the information for modifications in the diabetic formulas will come from outpatient practice. In the outpatient practice, 20-30 years has gone by, and nobody is going to be able to do research on this because it depends upon gut microbiome in various parts, depends upon, you cannot tell somebody take 45 grams of fiber every day. It is not sustainable. And therefore, I don't think there is going to be anything new that is going to happen unless some new molecule is discovered to improve insulin sensitivity. I don't know of anything particular that may help in it. But we do know in the community, we know that prevention of diabetes is something very important. It is being talked about by limiting the carbohydrate that we feed our children and our adolescents. Thank you.
Yes, sir. So now let me take, sir, if you may permit, let me take the liberty to put some animal studies and some human studies in the middle and think what would be the future in my opinion. Is that okay with you?
Sure.
Yeah. So as you rightly said, there are a lot of things that are not evidence based as of now, and this particular segment that I'm going to talk for maybe a minute, is probably going to be what I feel the future may hold in store for us when it comes to diabetes. And this is from a conference that I recently attended in endocrinology, which actually had a lot of animal studies that they put up. So it does appear that, as you rightly said, in those difficult to treat patients of diabetes, we might get a dose of chromium picolinate. We might get a dose of chromium picolinate that might help these patients. Another very important thing a very interesting thing was 7.5 grams of magnesium sulfate surprisingly reduces glycemic variability. 7.5 grams of magnesium sulfate given IV on a single day reduces glycemic variability. The other thing that you alluded to at the start, the small dose of vitamin D, there is some emerging data that in the patient whose vitamin D levels are less than 12.5, the supplementation of vitamin D does reduce glycemic variability. And surprisingly, a molecule that we thought will never work, alanine glutamine, at zero point 0.5 grams per kilogram, also is responsible for reducing glycemic variability. I thought, carnitine was only for the nerves till I attended this conference where I heard that a gram and a half of L-carnitine along with alpha lipoic acid again will actually reduce 900 milligrams to be precise, would actually come, as proven in many animal studies to actually get glycemic control under control. So I think the future, though doesn't appear very bright, we may have some answers to all of these things in the near future, is what I sincerely believe.
But
Sangamitra,
we have
so
very conflicting evidence, Dr. Sanjeev, regarding
correct,
this alcohol, all these things that you mentioned. A lot
correct,
of conflicting evidence is there. Some
correct,
studies say that
correct,
it will work, some say they don't. And there are
correct,
some
correct.
recommendations. That's a problem. I know.
Correct. So you're absolutely right. So that's why I said this 1 minute, 1.5 minute is something that I feel in the future may or may not come. But this is something that's a lot of data happening. On an average day, we have 5 or 6 papers coming out from here in the endocrine segment. So it's not related to nutrition, but in the endocrine segment, if you see endocrine papers, that's where you see most of these things.